I wanted to take the opportunity to introduce the next speaker, Dr. Freddie Bray. Freddie is from the International Agency for Research on Cancer, has been trotting around the globe, increasing capacity related to cancer registry, and we're excited to hear what he's doing and what the agency is doing related to this. Thank you so much.
Yes, okay. Thank you very much, Mona. Thank you also to Eduardo and Guillermo for the invite. It's a pleasure to be here, and it's a pleasure to have a discussion both on the burden of HPV-associated cancers, but also bring in population-based cancer registries and the need to capacity build across the world. And I want to just address a few of the issues surrounding the current HPV burden and the trends we see, particularly in cervical cancer. But I also want to talk about population-based registries and the global initiatives that we are doing. And as Savannah has said, that there is really a changing shift, a changing sort of need towards understanding the role of population-based cancer registries in planning and evaluating national cancer control programs generally. We had the global status report on NCDs. And more recently, we had the high-level summit in New York last year. And emerging is the action plan, the new action plan for 2013 to 20 from WHO. And as has been said, there's going to be cancer incidence as one of the indicators in the global monitoring framework. So there's hopefully going to be an emphasis on actually collecting this information at the national level. And alongside the targets, the voluntary targets for premature NCD mortality should give cancer registration an increased visibility and hopefully an increased number of resources at the national level. This is what's needed and what's perhaps been missing, and I'll go through that in some detail in time. And this is it's a somewhat bleak picture of where we are with cancer registration. Cancer incidence in 5 continents is the sort of reference volume for cancer incidence. We're about to publish a 10th volume for 2003 to 7, but this is for volume 9 and the status of cancer registrations circa 2000. And you can see that in the likes of Latin America and in Africa and in Asia, there's a paucity of high quality cancer registry data. But as I'll say later on, things aren't as bad as they seem. They are cancer registries in many of these countries. There's a need simply to try and improve and support the prospects for actually creating population-based cancer registries. So, as this is an HPV-related cancer conference, public health workshop, I wanted to just go through some of the basic patterns and trends we see in the HPV-related cancer burden in 2008, based on some recent work, and just talk a little bit about the patterns and trends, and then come on to this way we can try and improve cancer registration globally through initiatives coordinated by the International Agency for Research on Cancer, but using our multiple partners at the national, regional, and global level to try and instigate that. So just looking at the global related HPV burden, there are a couple papers that are published this year. One was in Lancet Oncology, looking at the general HPV-related infection burden, population attributable fraction due to HPV globally, as well as other infectious agents such as H. pylori and hepatitis B and C. And also within your packs, I guess, is this special issue of vaccine, and there's a specific paper on the global burden of HPV and related diseases, including genital warts. So I'll just give you some basic information on that. You know this already. There are 12.7 million new cases as estimated in 2008 of cancer, 7.6 million deaths. This is from GlobalCan, and by the end of 2012, about 29 million persons living with the disease diagnosed in the past 5 years. And the recent work has tried to re-estimate the extent to which cancer is related to infection. How many cancers? We estimate 16.1%, or about 2 million cases, are attributable to infection of the 12.7 million cases. And that was based predominantly on what were the epidemiologic studies that gave strong evidence for a relation between infection and cancer. As I say, these are the major cancers: stomach, liver, cervix, of course, related to H. pylori, hepatitis, and HPV generally, but other infectious-related agents and other cancer sites were examined and attributable fractions estimated. And this then is just looking at the HPV related cancers here in the red boxes, just to give you an idea of the PAF we estimated. We estimated it directly from the prevalence estimates based on various meta-analysis. Of course, 100% for as HPV is a virtually necessary cause of cervical cancer. And then for oropharynx, there's quite a lot of variation, and this will be discussed later in terms of the HPV prevalence related to specific subsites, of course, quite high in North America and parts of Europe, Australia, Japan, but very little data in the developing world, and difficult to tease out the effects of alcohol and tobacco as well. And then for vulva, anal and penile cancers, we estimated again from meta-analysis that there's a higher attributable fraction, of course, for anal cancers and vulva and penis cancer. And just looking then at the attributable fractions related then to the number of cases that are related to HPV. You can see here in the, see if I can get, yes. So these are the boxes. Yeah. These are the boxes that pertain to HPV-related cancers. So there's 610,000 altogether. I'm going to stop using that because the button's right next to the laser. Okay, now I know. So does that work? No, it doesn't work. Okay, it doesn't matter. So 610,000 cases overall, the vast majority in less developed regions, of course. And then there's a small proportion related to the other cancers, vulva, anal, penile, vagina, and emerging oral pharynx. And if we're looking at the context of all infectious-related cancers, we can see that there's a vast variability in terms of countries and regions and infection attributable fractions. So very high, 1/3 of all cancers are infection-related in Africa, going down to about 1 in 33 or so in Australia and New Zealand, 3.3%. And then if we just look then at those that are related directly to HPV infection, so these are the proportions that are attributable in different regions of the world. You can see that, for example, in sub-Saharan Africa, HPV-related infection takes about half of the total infection burden. Also very high in India, so it's the vast majority is HPV-related in terms of all infection-related cancers, but also in other parts of South and Central Asia, parts of Latin America, and also some of the Pacific Islands. And just looking at the patterns and trends and just looking at that broad dichotomy of more developed and less developed regions, cervical cancer is the 7th most common disease, but it's the 3rd most common in women. There are about 530,000 new cases of cervical cancer as estimated in 2008, 275,000 deaths. The vast majority, 85% of incidence, 88% of mortality occur in less developed countries. And in those regions, 13% of all female cancers are of the cervix. But we are in a world in transition. Many countries are transiting towards higher levels of human development, here measured in terms of the Human Development Index, which takes into account as well as GDP, education, and life expectancy. So there are many countries that have transited from what would be called developing countries, such as in Latin America, to higher levels of human development. So much of Latin America, for example, is now indicated as having a high level of human development. So there is a paradigm shift in what we consider to be developing, but there's still a lot of countries, particularly in sub-Saharan Africa, with low levels of human development. And it's in these countries, of course, where the incidence rates of cervical cancer are highest. You can see that in the bar chart on the right. There is a sort of dose-response relationship with level of human development. It's also cervical cancer is very high still in medium medium-level countries in terms of human development, partially because of India, because that's one of the countries in that Human Development Index category, and they're responsible. India has about one quarter of the cervical cancer incidence and mortality burden worldwide. But as you can see in the graph below, cervical cancer is the predominant cancer in sub-Saharan African countries, in both sexes combined. And this is a map. This is taking what Silvana showed for Latin America and just extending it. It's an analysis by Mark Arbin based on the global CAN estimates, and you can see there is a 40 to 50-fold variation here in the cervical cancer mortality rates, and the highest rates tend to be in much of sub-Saharan Africa, such as Uganda, Zimbabwe, but also in East Africa and the likes of Guinea and so forth. So there are high rates in a particular set of countries, also high, as has been said, in Latin America and parts of South and Central Asia. And there's a very extended variation in cervical cancer. This is just showing you the ranking of cervical cancer in 184 countries. The darkest countries are darkest blue and darkest red are the incidence and mortality rates that rank first according to all cancer sites. So this is where, if you like, we see the need for the greatest action. And it's worth pointing out that there's over 100 countries where cervical cancer incidence is the top ranking cancer worldwide, and about 90 for mortality. And there's a minority of cancers where cervical cancer is not in the top 5 cancers, and they, of course, predominantly are those countries that have attained the highest level of human development. So the rates are very high in terms of cumulative incidence. It's over 1 in 20 in a number of sub-Saharan countries, and this is showing you the top 10 and the bottom 10 cervical cancer cumulative incidence and mortality rates, and rates are very low in several highly resourced European countries, as well as countries in Western Asia and Northern Africa, which are predominantly Muslim populations with an associated different lifestyle, particularly in relation to sexual behavior. Generally, of course, and this has been mentioned, the type distribution varies between regions, but HPV 16 and 18 predominate in cervical cancer, from around 70 to 80%, depending on the region. This is perhaps difficult to see, but this is just giving you the prevalence estimates in women with normal cytology, and it's just to indicate when you're looking for a correlation between incidence and HPV prevalence, that there is one. The highest HPV prevalence tends to be in countries where cervical cancer incidence is high, such as Caribbean, Eastern Africa, Eastern European, as you see here perhaps, and much lower in the likes of Europe and North America. And there have been attempts to try and measure the correlation between HPV prevalence and cervical cancer incidence. This paper by Martin Plummer and colleagues looked at 13 cancer registries in terms of data from prevalence as well as incidence, and just tried to correlate the prevalence against the rates of incidence in different age groups. And there was a correlation. But the correlation wasn't as perhaps good as one might expect, but there are good reasons for that, and the reasons, of course, relate to quality in terms of both the completeness of the cancer incidence data and accuracy, as well as the representativeness of the sample of HPV, measurement errors in relation to HPV infection, whether we're measuring persistent or transient infections, but also confounding, and confounding can be things like smoking, changes in oral contraceptive use, reproductive factors. But the major one, of course, that sets the scene in terms of cervical cancer incidence worldwide these days is the impact that traditional cytological screening has had in some countries. And this is a very old map, so a very old graph. It pertains to data from 1943, at least in Denmark, up to 1980, but it indicates quite clearly the impact that cytological screening has had, and evidence for the effectiveness of cytological screening in reducing cervical cancer incidence over time. And the red lines here, you can see the dashed line is Finland, the block line is Sweden. You can see this, as there was high quality programs since the early 1960s, we've had a rapid reduction in cervical cancer incidence over a 20-year period up to 1980, and that continued, of course, into the 1990s, and an 80% effectiveness of cervical cancer screening. But the interesting thing was in the likes of Norway, where they didn't take up organised screening. This is a black dashed line. You can see that it continued up. The incidence increased gradually up to the 1970s, and opportunistic screening and ultimately organised screening was brought in therein. So this has had a huge impact in Nordic countries and many other countries, and Savannah's mentioned some of the impact in Latin America. Generally, we see rates going down in Europe, North America, Oceania. This is predominantly linked with organised or some opportunistic screening. There are exceptions, and there are many countries that are perhaps the former Soviet states where there hasn't been any organised and effective screening programs introduced. I perhaps concur with Savannah's comment that we're reaching a baseline in terms of incidence. There are probably different reasons for that in Latin America than there is in the likes of Sweden, but it seems that rates are beginning to stabilise in a number of countries. They're not being reduced by the same extent as they were in the 1990s. And I'll just go back, and these rates are obviously varying between 6 and 20. I'm just now moving to low and medium income countries, and you can see the rates are much higher. Zimbabwe the rates have apparently been decreasing, but there's evidence that they're increasing again. Uganda rates are increasing, very high rates indeed. And then in the likes of Thailand, Asia, Philippines, high rates, but they tend to be decreasing. The reasons for that are multiple, and I'll talk about India in a moment, and Latin America's been mentioned, and at least partially that's related to screening programs. Just looking at the percentage change, now this is just taking 101 cancer registries, looking at the period 1988 to 2002, so a 15-year period, and looking at the trend. This is the estimated annual percentage change, and most of these rates with these estimated annual percentage changes and their confidence intervals are below zero. So there's an indication that in medium, high, and very high countries in terms of human development, there is a reduction in cervical cancer incidence. And that plays in with this epidemiologic transition where we see generally rates of infection-related cancers coming down, and particularly in low and medium income countries. Same for stomach cancer, but there is this increased set of cancers more linked to westernization and so forth. But it's a mixed picture, and these, of course, are the high-quality registries. So we're missing much of Asia, Africa, and Latin America, and particularly Africa. I just point one or two countries where we see rates are actually increasing of the magnitude between 1 and 3%. As I say, Latvia, Lithuania, and Estonia, Baltic countries, former Soviet states, Slovenia, it's increasing, and also in some prefectures in Japan. Just moving to looking at some of the countries, both in Northern Africa and as well as in Eastern Europe and Central Asia, there really are a number of countries that do not have organised screening, for which mortality in young women is increasing. That includes Russia, Ukraine, Belarus, and you can contrast that here with the likes of Egypt with low rates and fairly stable rates. Kazakhstan's another where we see rather large increases in the last few years. And just looking at, you saw Finland at a very high rate in 1964, and of course that came down by 80% by the 1990s. There are many countries in these regions, for example, that have a cumulative risk that's as high or in the same order of magnitude as Finland was in 1964. And these, of course, are many of the countries where there's not been any screening programs in place, and they continue to have inefficient or programs are lacking entirely. This is a bit more complicated, but it's alluding to the reasons why there are these increases in the likes of Belarus and the Russian Federation. They're predominantly cohort related. So these, I think you can see from around 1940 on the left-hand side, these are birth cohort effects, and because these are increasing on a parallelly on a semi-log scale, these are a cohort effect. So this is actually changing sexual behavior, increasing the risk of persistent HPV infection, then increasing the rates of cervical cancer. And it's easier to see when you model this in an age period cohort model. This is something that you see throughout the world. There's a change in sexual behavior, changes in sexual mores that have increased the risk between 1930 and 1950, right up to the 1960s in women born in those subsequent generations. It's something you see everywhere, and you see it in Sweden. The difference in Sweden is the age standardized rates have come down because of screening. And just moving to a couple of countries in Asia, and the differences and the trends are quite complex. In India, this is based on Chennai and Mumbai. Partially, the decline in incidence isn't due to any screening programs. There's been very little of that in these urban areas, but it's changes in age at marriage. And actually, increasing age at marriage has meant that there's been an increasing age at sexual debut, which might be one of the reasons why there are cohort-specific declines in India. But you can see in the likes of Japan and China, actually, incidence is coming up in very recent generations. And again, that's related to changing sexual behavior among young persons, increasing the risk of high-risk infection and subsequently invasive cervical cancer. And just moving to Africa, and we're going to come on to talk about registries and the paucity of data. Uganda's one of the countries with precious data going back in time, and you can see here on the right, cervical cancer really is increasing. It's one of the highest rates, or the highest rate in the Kampala region of Uganda. And with that, one would say that the likes of prostate, breast, and not in this graph, colorectal cancer are increasing, and Kaposi's sarcoma, HIV-related cancers are relatively stable. So it's one of those countries that faces a double burden of a continuing westernization as well as a continued high level of infection-related cancers. So the projections would suggest, just based on demographics, assuming the rates in 2008 will stay the same, we'll have over 800,000 cases by 2030. But if we were to see that 2% decline that we saw on average in at least those 100 cancer registries, then we would at least be able to avert that increase, and the numbers would be around the same, around 530,000 cases, although the rates, of course, would come down. But the demographics are as such that population aging and growth is significantly increasing the number of patients that we are likely to see, irrespective of the rates. That, of course, is in the absence of the HPV vaccination, and of course that will have some impact even by 2030 in reducing the incidence of cervical cancer, at least in young women. Just briefly on anogenital cancers, the likes of anal cancer has been increasing. I'll mention oropharynx separately. It's been increasing in a number of populations. Of course, the rates of anal cancer in men having sex with men are about the same as cervical cancer in many sub-Saharan populations. It is increasing. It's been noted in the US and indeed in Denmark. Penile cancer has been increasing in some populations. There's very few populations for which we have this data, and there's a lot of random variation because of the relative rarity of these cancers. One, of course, is getting a lot of the attention, at least in Western population, is an increasing incidence of a subset of squamous cell carcinomas of the head and neck. So there's a number of studies now that have shown that there is an increase in the likes of oropharynx, base of tongue, and tonsil cancers. Some of those are actually related based on assays, so they've actually looked at the HPV detected cancers in the head and neck and seen increases both in the HPV prevalence and the HPV-16 positive predominantly cancers. And some of those are just simply based on looking at the more HPV-related cancers around the oropharynx. Along with that, of course, there have been increases in survival, which are particularly interesting in terms of seeing whether we can actually reduce the toxicity of treatment if patients are HPV positive. And of course that's related to a number of factors, the epidemiological studies, and Maura Gillison, I'm sure we'll talk about this later on. There is a dose-response relationship with oral sex and exposure to marijuana for HPV-16 positive cases, but not for the traditional forms of the traditional risk factors for head and neck cancer, tobacco, alcohol, and oral hygiene. And you can look at the trends in terms of more HPV positive and more HPV negative head and neck cancers. And this is difficult because, of course, just based on these subsites, much of the oropharynx cancers are still going to be related to tobacco and alcohol. And, in the likes of the US and Australia, you see that the HPV-positive cancers tend to be increasing, the HPV-negative cancers tend to be decreasing, but they're very variable depending on the country. In France, there's a very high level historically of alcohol and tobacco consumption. This is among men. So that will be probably the major reason that the rates are going down in both HPV-negative and HPV-positive cancers. And predominantly the increases are seen in men, particularly in the US, but in other highly developed countries. And it's just worth pointing out that still these are quite a small proportion in India, 20% and 10% in males and females respectively. So that's just a snapshot of the global burden. And were we to now move on to think about how population-based cancer registries can be used, really I couldn't present much of that information without population-based cancer data. It really is, on a global scale, absolutely necessary to understand what the global burden of HPV-related cancers is. And of course, on a national level, if we want to move forward and identify the extent to which the emerging screening programs for cervical cancer, as well as the long-term impact of HPV vaccination, we really need to have cancer registries in place. And, GlobalCan 2008, where we estimate the incidence, mortality, and so forth, is both a blessing and a curse in the sense that we were able to provide the cancer profile and burden in each country. But in some cases, when we're trying to capacity build cancer registries, ministries say, well, we already have the data in GlobalCan. So it's a real problem. And the countries here in the shades of green, really, in essence, are the countries where there really still remains to be, but there remains very little data, particularly in sub-Saharan Africa and parts of southeastern and central Asia. We really are missing data, and what we're trying to do at the agency is really try and capacity build. What a cancer registry is. It's responsible for the storage, analysis, interpretation of data. Now they can become quite advanced and be involved in biobanking and genetic counselling. But the basic cancer registry is about systematically collecting the data on occurrence, the characteristics and outcome of reportable cancers, with a view of helping assess, plan, control the impact of cancers within the community where the registry is based. So population-based cancer registries collect information on all new cases within a defined catchment population. It's usually defined by geography. And the main interest then is epidemiology, public health, planning and evaluating cancer control programs. There are other types of registries, and commonly they can serve as a backbone for population-based registries. Pathology-based registries are obviously collecting information from histologically diagnosed cancers in laboratories, but the population from which the tumour tissue is derived is not defined. Hospital-based registries, they obviously record all cases in one or more hospitals, but again, the population from which the cases come is not defined. We have no indication as to where those patients are coming from, and the extent to which a hospital-based registry reflects the reality in a specific community will depend on the types of cases that are coming into the hospital, and it has an impact on biases. I mean, if you look at it's old data, but if you look at the Mumbai Cancer Registry, mouth and pharynx, about 1/4 of the cases circa 1970, but almost half in terms of the hospital-based registry, because that's the sort of cases that are coming in and being diagnosed and treated. Similarly with pathology, the cancer registry here, the skin cancer is 1/5 in the population-based series, but much higher based on pathology in the pathology-based registry. So this is why we need cancer registries that are population-based. The requirements are clear definition of the catchment population. We need to derive those residents are living within the area and those from outside. There needs to be available medical care and ready access to the facilities. We have to assume that the great majority of cases do come into contact with the healthcare system at some duration point. There needs to be easy access to the case-finding sources, so it's critical to have collaboration with the hospitals, the pathology laboratories, and with the vital registration systems, and the availability of population data from the censuses is also a requirement. And this is extremely challenging in many low and medium income countries. We're not on a level playing field. The infrastructure is much more challenging, particularly in sub-Saharan Africa, but also in many parts of Asia and Latin America. So what we're doing about this, we've set up a global initiative for cancer registry development in low and medium income countries. It's about developing capacity. It's a response to the UN political declaration on the NCD, and it's also a continuing response to the action plan that is giving us the voluntary target of a 25% reduction in premature mortality for NCDs, as well as putting in cancer incidence as a key indicator for cancer morbidity. And really, the key mechanism is to set up a global set of network hubs, and we're working with our partners, you can see on the right-hand side, to attain a global fund to enable this to happen. So we have a regional hub in operation in Mumbai. It was inaugurated in October 2012. We're setting up a cancer registry hub in Izmir, and that's with support of the CGH of the NCI, as well as the Department of Cancer Control in the Ministry of Health in Turkey. And we also have a cancer registry network in Africa, sub-Saharan Africa, led by Max Parkin, of course, who's one of the pioneers of cancer registration and descriptive epidemiology. He continues to work with us. He's got an agreement with us, and he's also got a staff position now at the agency, so he's actually helping us expand the network in Africa. And the next step is to establish a hub in Latin America and Caribbean, and we're working with local partners to derive where that hub will be. So we have 3 hubs, and we want the hubs to, so far in terms of Mumbai, it's going to service predominantly South, Central and Eastern Asia. The hub in Izmir is going to service Western Asia and Northern Africa, and as I say, we have this network in sub-Saharan Africa, which is currently servicing many countries and expanding the cancer registry activities in sub-Saharan Africa. The general principle is trying to create on 4 levels a set of activities which will help improve cancer registration, help expand it where needed. We have a number of training courses in Asia, so I'm just focusing on Mumbai and what we're going to do in South and Central Asia. We have a number of courses coming on in Bangkok, Jakarta, Chennai. We have various research collaborations looking at the quality and evaluating the quality across and comparing the registries in India and Thailand. We're trying to create first reports of cancer incidence in Indonesia and Mongolia. We're going to put together a Cancer in Asia monograph as well. We have collaborative agreements based on site visits in Indonesia, Mongolia, Sri Lanka. This will be expanded. We have a number of site visits planned, and these are some of the countries we're going to in 2013, Bangladesh, Cambodia, Bhutan. I was in Nepal a few weeks ago, and Vietnam, just to see how things are doing, give recommendations and find ways we can improve them. So there's a number of things that are key requirements for population-based cancer registries. I won't go into details here, but evidently there needs to be an advisory committee. We need the cooperation and support of the medical community, and it goes without saying we need some clinical, some government commitment to enable sustainability. And the key thing actually is the leadership of the director who's going to be responsible for the success of the cancer registry, together with obvious things such as adequate staffing, expertise and training. The situation in Asia isn't so bad in the sense that there are only 6 countries where there's no data at all. There are many hospital-based registries, these lighter blue countries, and many countries have some registries at least that have been in the most recent volume of cancer incidence in 5 continents. The concept is to see where every country is by engaging with them. Some countries have no data, some have potential to become population-based, some have potential right now to become of CI5, cancer incidence of 5 quality. And some are already there. And it's really just trying to push these cancer registries to the next step through training, support, advocacy. And in essence, there are many this is just again South and East Asia. There's many high-quality population-based countries in China, India, Japan, some in the Philippines, Thailand, one or two in Vietnam. We have to monitor the situation there and try and improve the registries. In several of these countries, in the likes of Thailand and Vietnam, they're expanding the registries, and we have to make sure the old registries are still functioning. And then there's a series of countries where we see there's potential, and we're going to try and provide direct support to engage with the ministries and with the clinical community in trying to improve the cancer registries. In the likes of Indonesia, Mongolia and Sri Lanka, they're already embedded in the national cancer plans. We're going to try and improve the data. I'll mention that in a moment. And then potentially there are other countries we need to go and see how things are. There's hospital-based registries in Bangladesh, Bhutan, and Nepal. And this is my last slide, but it's just to indicate that in every country, what we actually need in terms of the support is quite variable. But there are some commonalities. In Sri Lanka, Mongolia, and Nepal, they've had hospital-based registries for varying parts of time. They have national cancer control plans in Sri Lanka and Mongolia, and cancer registries are embedded as part of those ongoing programs. In Nepal, there's no cancer plan, but we do have a direct aim to set up a population-based cancer registry in Colombo, in Sri Lanka, to expand the hospital-based registry in Mongolia, which is going to be national. It's a small population, but obviously a large area, and also potentially try and set something up in Kathmandu in Nepal. And the needs and the challenges are variable in each of these registries, and it's the same throughout the world. Sometimes there's a requirement for more staff. Almost always there's a need for a software system. We have something called CanReg 5 that does that. There's a need to evaluate the quality, and there's a need to use the data. The data's often in the back room, not being used by many people. It needs to be at the forefront. There needs to be reports generated showing the importance of this information. And in Nepal, there's still quite a lot of work to do. We need to get the hospital-based registry to function. There doesn't seem to be a commitment so far to population-based cancer registration. So every country is challenging, but we're trying to implement direct support where we can, where we see potential, and hopefully we will see a changing paradigm, and registries will be of value not only to assessing HPV-related burden and cervical cancer, for example, but also being able to assess tobacco control through lung cancer or westernization factors in colorectal cancer. So I'll leave you with this photograph. This was taken at the one on the left is the teaching hospital in Kathmandu, and this is the state of the medical records section. It's all paper-based, and we're trying to convert that into a functioning hospital-based registry. And as I said, we have a regional hub now in the Tata Memorial Hospital in Mumbai, and these are colleagues from Indonesia, Thailand, and Sri Lanka being trained over a 2-week period in October. So hopefully we will be able to continue to expand the quality of data and be able to provide trends in more countries than we see here, both in terms of HPV-related cancers, but for all types of cancer to ameliorate the cancer burden in the future. Thank you very much.